the next session will be presented by Dr. Nasser AL-ASMAR, who is the scientific advisor and then embryology director in Igenomix headquarters. Dr. Nasser has over 15 years clinical and research laboratory experience, mostly with the Igenomix affiliates from the IVF Valencia to US, and now he's back to Spain for the global advisory role. And Dr. Nasser has made many speeches on international congress and conferences in several countries, like Argentina, India, Nigeria, Kuwait, Japan, Hong Kong, also Spain. And today is his first speech, even it's online the speech Korean audience. So let's welcome to the Dr. Nasser for his topic as ERA endometrium matters. Dr. Nasser, please start your presentation.
Thank you very much, Damian, for the nice presentation. It is for me a pleasure as well to be here today with the Korea people, my Korean colleagues, and well, I'm going to try to explain why the endometrium matters. Because as Dr. Carmen Rubio explained, the embryo is really important in order to get implantation into the uterus. But I want to show you why the endometrium matters. And this is the maternal contribution. We do know that for the process of the implantation, it's really important different parts, because there's such a things such as the endometrial microbiota, the maternal-embryonic crosstalk, the process of decidualization, and also the endometrial receptivity that actually is going to be the topic of the first part of this talk. And from the past several years, we were analyzing a lot the sperm, the oocytes, even the embryos, but looks like that when we do the transfer, we close our eyes, we cross our fingers, and let's see what happens. And here in Igenomix, we're really interested in to analyze the endometrium, and actually we published this paper back in 2011 when we found a genomic diagnostic tool for the human endometrial receptivity that was based on the transcriptomic signature. At that time, we were able to publish already 238 genes that were up or down regulated in the exactly moment of the window of implantation. That means that the moment when the embryo, the endometrium is receptive for the embryo. In this case, in this paper, we publish the by array, microarray. So you can see here the signature, and this signature is telling us if a patient is receptive or non-receptive in this such a time. So let me show you an example of an HRT cycle. We can perform the ERA test with natural cycle, with a combined cycle, and with hormone replacement therapy cycle. And as far as when you have a patient that is receptive on the biopsy, and you have to perform exactly the same, you have to replicate exactly the same for the transfer cycle, meaning same days of progesterone, same hours of progesterone, same way of administration, and same dosage of progesterone. And as you may know, the HRT cycle is the easier in order to replicate. And this is why we are receiving right now around 95 to 98% of the cases of the cycles for the biopsies in HRT cycle. So you will start with estradiol up to day 7 to day 10, and then you will perform a vaginal ultrasound just to check that you have a triple layer endometrium, that it has to be thicker than 6.5 millimeters. And at that point, it's really very, very important to measure the endogenous progesterone. And this has to be under 1 nanogram per milliliter. If the endogenous progesterone at this point is higher than 1 nanogram per milliliter, we do recommend to cancel the cycle because this can affect to the final result. So having the endogenous progesterone under 1 nanogram per milliliter, then within the next 24 hours, we can start with the exogenous progesterone intake. And we will provide this progesterone intake for 5 full days or 120 hours when we will perform the endometrial biopsy. Why at this point? Because as you can see later on, most of the patients are going to be receptive at this certain time. And let me show you a short video about how you have to collect the sample or do the endometrial biopsy.
The ERA test, patented by Igenomix in 2009, evaluates the receptivity of the endometrium, identifying the unique window of implantation for each patient to perform a personalized embryo transfer. This test requires a small sample of endometrial tissue. This biopsy is quick and easily taken by a physician in their exam room. Have the patient lie in gynecological position. Insert the speculum into the vagina. Clean the vagina with a dry cotton swab to remove vaginal mucus or progesterone. Introduce the biopsy catheter into the vagina, avoiding contact with the vaginal walls through the cervical os to the uterus without touching its bottom or scraping its walls. Once inside, keep the catheter or cannula in a fixed position inside the uterine cavity. Connect the 10 milliliter syringe and perform the constant suction while scraping the walls of the endometrial cavity from above about 3 or 4 times. Maintaining the aspiration, begin to withdraw the cannula and stop it only when beginning to pass through the internal cervical os. Completely remove the catheter connected to the syringe, avoiding the contact with the vaginal walls. Clean the outside of the catheter with gauze to remove traces of cervical mucus. Deposit the sample in the tube. Close the tube and shake vigorously for several seconds. In case of difficult access in the endometrial cavity, a transfer cannula can be used with its guide. Pass through the internal cervical orifice and reach the site of the sample. Then remove the cannula and guide and cut the cannula with the scissors at the area where it begins to thicken and reintroduce it to the bottom of the uterus. It is normal to feel negative pressure when operating the plunger while performing the biopsy. Label the tube with the patient's name, date of birth, and date of biopsy, and store in a refrigerator at 4 to 8 degrees Celsius for at least 4 hours before shipping.
Okay, so the action protocol will be like at the very beginning, we have to select when we would like to do in HRT or natural cycle. We have to decide it. And then we will take a biopsy during the estimated window of implantation. As I said, in HRT cycle should be after 5 full days of progesterone or around 120 hours. And in a natural cycle should be in LH plus 7 or HCG plus 7, meaning that LH, the search of LH, it's LH plus 0. So it's next 7 days. So once we have the biopsy, we have to place it on the cryotube, and it's important a couple of steps. The first one is that the quantity of tissue must not exceed 1/3 of the total volume of the cryotube. We have RNA inside in order to preserve, to protect the sample. As you might know, the RNA is easier to degrade than the DNA. So as far as we are looking for the RNA of the human endometrium, we need to be sure that it's going to be properly preserved. we have to label the cryotube and shake it vigorously for 10 seconds. So we are going to be sure that all the sample is with the RNA later embedded in this solution. And then the other key point in here is to place the sample in the refrigerator between 4 to 8 Celsius degrees for a minimum of 4 hours. After these 4 hours, it can remain even longer, or you can send right away the sample at room temperature without any problem. So I said that we started doing the ERA in the past with the microarray, but a few years ago, we moved into the NGS. And we are analyzing right now 248 genes. It's 238 plus 10 genes for housekeeping, for controls. And then we do a bioinformatic data analysis and perform the classification and prediction from the gene expression. Doing this move from microarray and NGS allowed us also to retrain the ERA algorithm to be more precise. So now we can tell you if your patient is going to be receptive, but also if the patient is early receptive or late receptive. And I will explain you later why this is important. As well, if the patient is non-receptive, either pre-receptive or post-receptive, or if the patient is on a stage of proliferative. How about the science in here? Well, we have over 20 publications regarding ERA, but also ERA external publications where some groups perform the ERA in their own clinics and they publish their results without anybody from Igenomix involved. So this is supporting really our studies. About the global ERA data, I would like to show you some numbers. You can see that there's more than 125,000 patients already analyzed from 4,000 clinics all around the world in 90 countries. And as an example, also telling you that during 2020, almost 30% of the patients when they went an ERA test requested also the endometrial test. That means the 3 tests that we perform for the human endometrium. As a global ERA data, I can tell you that around 62% of the patients were receptive and 33% were non-receptive. And how can we classify all of them? Well, we will have around 1% of patients that are going to be early pre-receptive. Around 30% of the patients are going to be pre-receptive. That means that they need 1 or 2 days more of progesterone. We will have around 16% of patients that are going to be early receptive. Around 40%, most of the patients, as I said before, that are going to be receptive. 5% that are going to be late receptive, and 2.6% of patients that will be post-receptive. That means that they will need 1 or 2 days more of progesterone. The good thing also, when we move from the microarray to the NGS, that we are able to retrain the algorithm of the ERA, is that right now, only with 1 biopsy, in 92% of the cases, we can tell you about the personalized embryo transfer. That means that you don't need to make a second biopsy in order to make the transfer. So in all of these cases, we can tell you, okay, go ahead and make the transfer for the patient, even if patient is receptive, but also if it's early receptive, pre-receptive, or late receptive. So you don't need a second biopsy. That means in a second biopsy, you have to pay for this second biopsy. You have to wait another month for the patient, and then also you have to make a procedure that is kind of invasive. So this is going to happen only in less than 10% of the cases. Before, we used to do this in 30% of the cases. So we improved a lot the way to analyze it. And let me show you, to finalize the part of the endometrial receptivity, with this study that we published last year, that was a 5-year multicenter randomized controlled trial, where we were comparing 3 different branches. First one was a branch that we call personalized embryo transfer. That means that you perform the ERA on the patient and you perform the transfer according what the ERA tells you. The second branch was the branch for frozen embryo transfer. You get the embryos, you freeze them, blastocyst stage, and then in another cycle, you transfer them. And the third branch was the fresh embryo transfer. You grow the embryos and you transfer right away. So let me show you that we started with more than 550 patients. We were able to randomize 458 and allocate in the 3 different branches, again, personalized embryo transfer after performing ERA, frozen embryo transfer without ERA, and fresh embryo transfer without ERA again. And you can see that we had around 140, 150 patients per intention to treat, but I'm gonna show you the results for the patients per protocol. I do know the importance per intention to treat, but for me, if I want to show you that the test is useful or it's working or not, I have to follow the protocol. So this is why I emphasize at the per protocol analysis. And let me show you these reproductive outcomes so you can see that there were several measurements, but let me focus in these 5. So first one, we have reproductive outcomes at the first embryo transfer. And as you can see, pregnancy rate was 58.5% in fresh embryo transfer versus 54.3% in frozen embryo transfer versus 72.5% in personalized embryo transfer after performing an ERA and performing the transfer when the patient was receptive. Then we had implantation rate. We had 38.6% for fresh embryo transfer, 43.2% for frozen embryo transfer, and 57.3% for personalized embryo transfer, being all of this statistically significant. It was not the live birth rate, again, at the first embryo transfer, but you can see that for fresh, we had 45.7%, for frozen, we had 42.4%, and for personalized embryo transfer, we had 56.2%. So we do believe, and I will explain in the next slide, that we didn't reach the statistical significance because the number of dropouts that we had unexpected. But as you can see, we had for both fresh and frozen more than 10 percentage points higher the live birth rate in the group of personalized embryo transfer at the first embryo transfer. So then we move to the results, cumulative results during the 1-year follow-up. That means you perform a transfer, patient don't get pregnant, so you perform another transfer, patient don't get pregnant, you perform another transfer until patient gets pregnant or until 1 year, then you stop. So you can see the cumulative pregnancy rate for fresh embryo transfer, it was almost 63%. For frozen embryo transfer, it was 70%. And for personalized embryo transfer, it was 95%. And cumulative live birth rate, it was almost 50% for fresh embryo transfer, 55% for frozen embryo transfer, and 71.2% for personalized embryo transfer, being all of this statistically significant. So for the take-home message for this study per protocol analysis would be that we had implantation rate increase in personalized embryo transfer in 14 percentage points versus frozen and 18 percentage points versus fresh. Pregnancy rate increased in personalized embryo transfer in 18 percentage points versus frozen and 14 percentage points versus fresh embryo transfer. Cumulative pregnancy rate increased in personalized embryo transfer in 24 percentage point versus frozen and 32 percentage point versus fresh embryo transfer. Live birth rate increased in personalized embryo transfer in 13 percentage points in frozen and 10.5% versus fresh embryo transfer. And cumulative live birth rate increased in personalized embryo transfer in almost 16 percentage point versus frozen and 22 percentage point versus fresh. So the limitations, as every study has, is that the main limitation, as I said before, of our study was the unexpected added 20% dropout rate versus the 30% initially planned, because it was a study performed in 16 centers in 3 different continents, so it was a little bit tough in order to do the follow-up even more at the very beginning. Also, that the study was powered to detect statistical differences for a 15 percentage points increase, but we do think that this is the first RCT to provide a proof of principle evidence for the potential of using a personalized diagnosis of the endometrial factor in the workup of in the infertile couple at the first appointment, because this study was performed with patients at first appointment at the clinic. So there's no implantation failure on those patients. There was not recurrent miscarriage. There was not advanced maternal age for those patients. They were removed from the study. And let's move to the second part of the talk. And let me tell you something about endometrial microbiota. Because we used to know that the medicine books used to tell us that the uterus, the endometrium, is something that is sterile. There is nothing there, but we do know nowadays that this is not really true. And in 2008, the NIH started a project called the Human Microbiome Project, and they wanted to map a healthy human microbiome in different parts of the body, at the airways, at the skin, at the oral part, at the gastrointestinal tract, but also the one that is most interesting for us, that is the urogenital tract. You can observe that in a healthy human, we do have the most part of our microbiome at the urogenital tract is for lactobacilli, and this is something that we are going to comment in this part of the talk. Just as a brief summary, humans have 10 times more bacteria than cells living in our body. It's especially abundant in the skin and the digestive tract. In a person weighing 70 kilograms, 1 kilogram is due to bacteria cohabitant in our body. And this is important to know, and I will explain you later on why. Between 20 and 60% of these bacteria, depending on the location, are not cultivable under standard laboratory conditions. Saying that, we did our own research and were able to publish this paper back in December 2016, where the objective was, first of all, check the existence of an endometrial microbiota, and also to see and analyze the possible impact of this endometrial microbiota community on the reproductive outcomes in infertile patients coming to our IVF centers. So the first part of the study was to check the vaginal microbiome and the endometrial microbiome. And as you can see at the figures, they were pretty similar, but also we find that they were different. Those was performed in fertile patients, and you can see that even though we're so similar, we found some bacteria only at the endometrial samples. So this means that there are similar, but at the same time, they are kind of different. And also checking that the lactobacilli was the most abundant genus that was published by other groups like Tao or Kiono in the different papers. So let's move to the second part of the analysis. Then we check for infertile patients. We perform endometrial fluid for the microbiota analysis to see if there is healthy microbiota or it was a dysbiosis, it was altered microbiota, and perform an endometrial biopsy on the same patient to check if the patient was receptive or non-receptive. So then we can measure the endometrial microbiota and the receptivity. For those patients that were receptive, we perform the transfer and check if they got pregnant or not in order to compare endometrial microbiota and the implantation. And for those patients that got pregnant, we did the follow-up in order to see if there's an ongoing pregnancy or unfortunately they had a miscarriage. So then we can check the endometrial microbiota versus the pregnancy outcome. So with the help of our team of bioinformatics, we were able to do a cutoff from the patients. You can see in this heat map on the bottom, we have the patients. On the right side, we have all the most prevalent bacteria, even though these 4 most prevalent: lactobacilli, streptococcus, bifidobacterium, and Gardnerella. So, well, our bioinformatics team helped us in order to make a cutoff, and in this case, we put the cutoff in 90%. Patient with 90% of more of lactobacilli in the endometrium were called patient with a microbiota lactobacilli dominant, and patients with less than 90% of lactobacilli in the endometrium were called patients with non-lactobacillate dominated microbiota. And with this cutoff, we move into the reproductive outcomes. And as you can see, this table, we will have first column is patient with lactobacillate dominant microbiota, more than 90% or 90%. Second column is non-lactobacillate dominant microbiota. You can check pregnancy rate per transfer, non-lactobacillite dominant 33% versus 70% in lactobacillite dominant patients. Implantation rate per transfer, 23% in non-lactobacillite dominant microbiota versus 60% in lactobacillite dominant patients. Ongoing pregnancy rate per transfer, 13% versus almost 60%. And live birth rate per transfer, again, 7% non-lactobacillite dominant versus almost 60% in lactobacillite dominant patients. So all of this was statistically significant. It was not the miscarriage rate that went down from 60% to 17% because probably the number of patients. And I can tell you that this was the first study, but the second one just had been accepted for publication. So in the next weeks, we were able to show you the results, and I can tell you that we performed this in more than 300 patients, and the results are pretty similar that I'm showing you right now. So we will be able to share with you. If you are interested, we can send you the paper once it's published. And as you can see here, patient with a live birth, it has most of the population, it's lactobacilli, but when you move to patient with a miscarriage of a non-pregnancy, we do have less of lactobacilli and more of other bacteria or pathogens such as Gardnerella. So this tells us that a non-lactobacillite microbiome, especially with the presence of Gardnerella and Streptococcus, correlates with adverse reproductive outcomes when compared to patients presenting with an endometrial lactobacillite dominant microbiome. And the percentage of lactobacillite present in the endometrium is a significant variable to predict reproductive success. Let's move to the last but not least part of the talk, and I'm going to talk about chronic endometritis, that, as you all know, it's a persistent inflammation of the endometrial lining that is mainly caused by bacterial infection with common pathogens such as Staphylococcus, Streptococcus, and so on. Usually it's asymptomatic, and those seldom diagnosed and treated. It's really hard to know if there's something in there, and also to treat. The estimated prevalence is 0.8 and 20% in general population and 30% in infertile patients. Chronic endometritis might influence the reproductive function, decreasing the success rates in ART and increasing obstetrical complications. There's no detectable by ultrasound. The gold standard nowadays is histology, but we can perform hysteroscopy and microbial culture. And the most frequent treatment is an antibiotic therapy with a broad spectrum antibiotics. So this is why we came back in 2018 with this paper published in American Journal of Obstetrics and Gynecology, where we wanted to have and to develop a molecular diagnostic tool. At that time, we performed with real-time PCR, but after that, we moved into the next generation sequencing to try to diagnose their chronic endometritis. Instead, the 3 classical methods that we do know that are kind of subjective, overcoming the bias of using any of them alone. So those are the chronic endometritis pathogens that we were analyzing. And first thing that we perform, and this is a paper published together with Dr. Ettore Ciccinelli at Bari University, that there are great experts into the chronic endometritis. You can see that the first thing that we found is that when they try to analyze same sample for the 3 different classic methods, again, histology, hysteroscopy, or microbial culture, they only found 20% concordance in between them. So then we took those that were concordance, either positive or negative for the 3 of them, because at that point we do know that they are really clear. Then we did it by our test, and we can confirm that we have almost 80% concordance. Okay, so then this was with real-time PCR. When we moved into the NGS, we found a 92% concordance. So we were able to move the technology and start performing the test with this kind of technology. So at the end, with these results using NGS, we're consistent with the real-time PCR, as I said, 92% of the cases, and coincident also with the microbial culture in 75% of the cases, allowing the detection of cultivable and non-cultivable bacteria. And remember that I said before, between 20 to 60% of bacteria cannot be cultivable depending on the location. So this is why it's important. And also that the molecular diagnosis of chronic endometritis would be equivalent to the use of the 3 classical methods together, making it more objective and robust against each of the traditional methods separately. Because in all the clinics that I give this kind of lecture, they tell me, okay, I use one of the methods, I use 2 of the methods, but as far as of today, I never had any clinic that used the 3 of them. So then we can conclude with the endometrial microbiome analysis that the vaginal and endometrial microbiome are quite similar, but also different, that the lactobacilli is the most abundant genus in the endometrium. A lactobacilli dominant endometrium is associated with a better reproductive prognosis in IVF patients. The presence of pathogens in the endometrium is associated with implantation failure, recurrent miscarriage, preterm birth, and so on. And chronic endometritis can be better diagnosed by molecular methods such as NGS. And this is why we came with 2 different tests, that the name is Emma and Alice, for the study of the microbiome and the chronic endometritis. So let me show you an updated global Emma and Alice data. And you can see that we already performed more than 29,000 samples analyzed from 40 different countries. During 2020, almost 30% of the patients underwent ENMA analysis, and 72% requested the Endometrial, so the 3 different tests. And it's important to know as well that 98% of the patients underwent an ENMA test. ENMA included ALICE, but only 2% requested only the ALICE test, only the chronic endometritis test. And this is important because with the ENMA, we check everything, microbiome and chronic endometritis. With ALICE, you only check for chronic endometritis. And you might be missing something. And let me show you this. Those are total samples analyzed in the first biopsy. And you can see that we can have a result that is abnormal positive. This means that this result is positive for chronic endometritis, and this is happening in around 9–10% of the cases. But you can observe in here that we do have 14% of cases such as abnormal negative. Abnormal negative means that we have negative for chronic endometritis, but positive for other tests, other pathogens that are not causing chronic endometritis, but are causing infection. So they need treatment with antibiotics. So we perform only chronic endometritis analysis. We might be missing this part of here. Also, we have around 30% of microbiome with ultra-low biomass. That means that we find that there's few bacteria on the endometrium, but we can observe that there's no one pathogen in there. Milk dysbiosis profile, that is that we have lower quantity of lactobacilli and around 25% of results that we find in normal. These results means that we do need around 25% of the cases to perform treatment with antibiotics, and 75% of the cases, we do need to provide probiotic to the patients. So the results could be, as I said, normal negative. The recommendation would be then perform the embryo transfer in the next cycle, ultra low biomass or mild dysbiosis, that we will ask to do a treatment with probiotics and then perform the transfer in the next cycle. ENMA abnormal but ALICE negative or ENMA abnormal and ALICE positive, we will ask for a new biopsy after a recommended antibiotic probiotics treatment, because we would like to be sure that we amended the situation, that we removed completely the bacteria prior to perform the embryo transfer. So just to conclude, let me tell you that the transcriptomic signature reveals that the endometrial factor is responsible for 30% of the cases of patients with recurrent implantation failure. A non-lactobacilli dominant microbiome correlates with adverse reproductive outcomes when compared to lactobacilli dominant patients. The molecular techniques effectively detect and quantify the bacterial DNA of pathogens causing chronic endometritis. We can perform right now a complete endometrial health study. That means endometrial receptivity, microbiome, and chronic endometritis with a single endometrial biopsy. And this is what we are calling endometrio again. Only with one biopsy, we can perform this 360 degrees endometrial health analysis. Thank you very much. And let me try to ask your questions. Thank you again for your presence here.
Thank you for your splendid presentation, Dr. Nasser. Now we have a Q&A session for him about the ERA and EMMA. So you can, I have the 3 questions already. So let's start from the question first. The 380 genes used for the window implantation were identified using gene expression technology. So we'd like to know ask if Igenomix validate those genes in different population, most especially for the Asia Pacific population. Thank you. Dr.
Thank
Nasser.
you, Damian. Oh, yes. The good thing, as you explained in your introduction at the very beginning, is that we have labs all around the world. So we, at the very beginning, we started with mostly with European and American population. But right now, we are conducting analysis and studies all around the world. So as you know, we use an artificial intelligence in order to make better the tool of the ERA each time. So we are growing the tool with patients all around the world, including, of course, patients from Asia and Pacific. So I can tell you that this tool is proven for patients worldwide.
Thank you for your splendid answer. So the next question I will go over. This is the question from the Dr. Chong, who was the APEC Symposium speaker from the Seoul Lahel. So this is question in English. When transfer cleavage embryos, it is recommended to be transferred 48 hours before the recommended time. But I do not think it is an inappropriate recommended time for ERA. Also, I did not see any result for the cleavage transfer in the papers. If you have any experience, result of cleavage embryo transfer or the future development plan, please share.
Okay, this is the recommendation that we do based on the original data from on day 3. We do know that the implantation should be around day 5, 120 hours. This should be the normal. So then the recommendation to do 2 days early in a cleavage stage is based on the regular basis. Okay, so for us is kind of smart thinking in order to, if we move the blastocyst transfer from day 5 to day 6, then the cleavage stage that should be on day 3, the transfer, then we have to move to day 4, because this is what a regular basis happens in the human body, that the implantation happens 120 hours after the phase intake of progesterone, around day 5. So then the cleavage stage should be 2 days earlier. But it's true that we conducted our studies always in blastocyst stage, not in day 3, mostly also because there's a trend from the last years to now doing the transference on blastocyst stage. And this is why we are always putting our recommendation for blastocyst stage. But then when we do recommend to do a cleavage stage, we also say, okay, you can remove 2 days, because we do think that physiology of the body is what that works like this. The regular or the usually implantation happens at day 5. So then if we want to transfer a cleavage stage embryo, then we should remove 2 hours.
Thank you again for the full explanation about the cleavage stage transfer too. I have the question about this EMMA at this time. Here is a question. The type of lactobacillus species is also important in the endometrium microbiome, such as Lactobacillus cristapatus. Do you have any plan to analyze the species as well, especially for the lactobacillus?
Yeah, actually, we do have in our diagnostic team, we have microbiologists in charge to recommend a specific species of lactobacilli and or antibiotics independent of the cause. So what we did is to check a different list in different regions of probiotics that are available. So you will have for sure a list of probiotics that are available in the APAC region. So we check that all of them are consistent and are good in order to treat the patients, because yeah, it's right that this matters, the species of the lactobacillus. So this is why we always like to make a treatment specific for the patient and for the cause of the dysbiosis or the chronic endometritis. And also we have always this medical team for the EMMA analysis, and also another for the ERA, but in this case for the EMMA analysis. So the doctor, even though start doing the probiotics or the antibiotics, they can check with them, okay, I'm going to provide this and that. Is that okay for you? So our team of microbiologists and the medical team will provide with counseling about if they should perform this or that. So yeah, we will be on top of this because we do think that this really matters.
That would be good for the EMMA analysis, more detailed thing. There is 2 more questions. If Dr. Chu can wait for 5 minutes, then I will proceed 2 more. Is it okay? Yeah, I got the agreed from the Dr. Chu. So please be patient for the Dr. Chu's presentation waiting. 1 more is for the EMMA. This is more clinical the case. Here is it. If a woman is diagnosed with a problem in microbiome in her vagina through EMMA analysis, is it possible for her to be pregnant naturally if she will be treated?
Okay, I think that it's in endometrium because we don't analyze vagina, we do analyze endometrium. We do analyze endometrium because, as I showed the presentation, it's similar but different microbiome, and we would like to go deep inside because it's the place where the endometrium implants. And the question is, yes, it might happen. Actually, there was a physician that came to me in a congress, and he made me a joke, but he came like seriously telling me, hey Nasser, you kill 1 cycle of one of my patients. Say, why? Say, the patient had a microbiome that was alterated, and I provided probiotics, and before to come back to the clinic, she got pregnant. So I missed the next cycle. I couldn't make the next cycle. So, well, this is kind of joke that the physician told me. Of course, they can get pregnant if you treat it, but naturally, but usually you perform this in the next cycle because in each cycle can change the microbiome with the menstruation, with the sexual relations. So yeah, they can try it to do it naturally, but usually what they recommend is, okay, you have everything ready, you perform the test, you perform something that altered it, you treat it, and then you perform the transfer. But yeah, the answer would be it can get pregnant naturally after the treatment.
Okay, thank you, Dr. Nasser. This is the last question from the Korean audience. Was related also to for the treatment of lactobacillus. Have you ever seen a difference in treatment depending on the type of lactobacillus recommended?
Well, this is something that we are trying to check in order to try to more specific. So far, we didn't have an answer in order if we have different treatments because it's hard to do the follow-up. We do know that the clinics are very busy. So do this kind of research for us is sometimes tricky because we don't know first which one of the probiotics are providing and then the outcomes at the end. But we would love to have this in order to be even more specifics in order to make the treatment. But the thing is that we always perform a recommendation, but the final decision is about the doctor. So even though we say, okay, the recommendation would be this specific, the doctor might change his mind because his experience or anything that he may think that it's better for the patient. So after our recommendation, we usually don't know which one they are transferring. So this is why it's so hard in order to follow up if any species is working better or not. We are always looking for new papers and new research in order to know what is the new thing, which one is working better or not, in order to try to, okay, let's recommend this because it looks like that it works better the other one. But would be, I think, a great research. So if any clinic thinks that this could be interesting for his patients, we will be more than happy to try to do some research together.
Thank you for your wonderful answer, and then will be great future for our EMMA test too. Let's finish up to the Dr. Nasser's speech, and again, we really appreciate about all the full presentation and Q&A session, Dr. Nasser.
It is my pleasure, Damian. And please, next time I will be there in order to give the presentation, not by webinar.
Sure. Yeah, live thing is best.